Morning everyone, a big welcome from Bemax Academy. So this is part of our monthly series where we share our limited amount of knowledge with all the patrons we have. So this is the day where we share a specific topic with you. Today we have selected knee joint special test, which is a very important topic in the licensor exam. So as you know, Bemax is committed to provide you best resources and training program which equips you in the best way possible to crack the licensor exam. So without wasting much of your precious time, let me introduce myself. My name is Bibin Prasannan. I am the instructor for your physiotherapy licensor exam. So today we are going to discuss about knee joint special test. So before going deep into the knee joint special test scenario, what we need to understand that it's not an isolated joint. We have to view it in a multi-dimensional way. So there are certain structures which are injury prone when excessive of compression is applied. There are some structures which are prone for injury when we give excessive distraction. And for each of the special tests, there are special degrees and ranges whereby which we elicit the symptoms in the patient. So it's very important to know all these things. So today what I have done is I have just flipped the page. So I'll be dealing in detail with the theory aspect of the knee joint in a short and concise manner, and I'll be sharing the MCQs and let you people come to a conclusion regarding the answer rather than I telling you the correct option. So I request you wholeheartedly to concentrate to the full topic, give emphasis to the degrees and the specific points that we are noting down for you guys. And then when we are going to discuss the question answer session, this will help you in refining your thoughts and coming to the perfect answer. So let's start. So first we are going to deal with the collateral ligament stability test. We know that there are two collateral ligaments, medial and lateral collateral ligaments. As the name suggests, they are present in the medial and lateral aspect of the knee joint, and we do stress testing to find out the laxity of the collateral ligaments. So the purpose of the collateral ligament test is to check for the ligament laxity or restriction. Whenever there is a restriction or laxity, we want to do the joint plate test to know whether there is restriction or laxity present. So instability test means we are checking specific for the laxity. So here the patient is in supine, the knee joint is flexed to 20 to 30 degree. So for medial collateral ligament, we always give a valgus stress. So what do you mean by valgus stress or valgus force? When we are trying to push the knee joint inside towards the inside direction, that is called as a valgus force. So valgus force, this valgus force mainly helps in stressing the medial collateral ligament. And for lateral collateral ligament, we always give a varus force. So this varus force helps in stress testing the lateral collateral ligament. So the position is very important. There is a 20 to 30 degree knee joint flexion, and a valgus and varus force is applied to differentiate between medial collateral ligament and lateral collateral ligament. Depending upon the joint play that a examiner or the therapist gets, we come to a conclusion where there is a laxity or a certain possibility of rupture is present. So patient is in supine, knee is flexed to 20 to 30 degree. We are applying a valgus force which tests mainly for the medial collateral ligament, and for checking the lateral collateral ligament, we are doing a varus stress test. So the range, knee joint is flexed to 20 to 30 degree. Coming to cruciate ligament test. So we know like the collateral ligament, we have got cruciate ligament, anterior cruciate ligament and posterior cruciate ligament. As the name suggests, they are cruciform, which comes in a crisscross manner. That's why the name anterior cruciate and posterior cruciate ligament. So the first test is Lashman's test. This Lashman's test checks for the integrity of anterior cruciate ligament. So here also the patient is in supine and the knee joint is flexed 20 to 30 degree. So therapist stabilizes the femur, and we know that anterior cruciate ligament, the main purpose of anterior cruciate ligament is to prevent the excessive anterior translation. Okay, prevent the excessive anterior translation of the tibia. So therapist holds the femur and then he gives an excessive anterior glide to the tibia. So while examining, if we feel that there is excessive anterior glide or anterior movement to the tibia, that shows a perfect sign that the Lashman's test is positive. So if we can see that there is an excessive anterior glide, that indicates that Lashman's test is positive. So stress test for anterior cruciate ligament, knee patient is in supine, knee joint is flexed to 20 to 30 degree. Pivot shift test. So pivot shift test checks for anterolateral rotatory instability. So when we talk about the stability of the knee joint, we can consider knee joint as different quadrants, right? Anteriorly we have the anterior cruciate ligament, posteriorly we have the posterior cruciate ligament, medially we have medial collateral ligament, laterally we have lateral collateral ligament. So when we hear the term anteromedial instability, what does it signify? It signifies that both anterior cruciate ligament and medial collateral ligament might be involved. So these are some concepts that we learn by understanding. This can't be simply mugged up. So we need to know medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, posterior cruciate ligament, where these are located and which all directions they give stability, and then depending upon the name, anteromedial instability, anterolateral instability, we can come to a conclusion that which structures might be at fault. So pivot shift test, here we are going to check mainly regarding the anterolateral rotatory instability. So here the patient is in supine with knee joint extended. So the hip joint is flexed and abducted to 30 degree and it is slightly internally rotated. So here what we do is we are applying a valgus stress test, and this valgus stress test is applied when the knee joint is flexed. So a positive sign is like if the tibia is dislocated, it will give sign of a relocation sound or sort of a clunk sound. So that is called as relocation. So whenever we are trying to give a valgus force and trying to relocate the tibia, we can hear a clunk sound. So this clunk sound is basically due to the presence of a iliotibial band which tries to put the tibia back in space. So that's regarding pivot shift test, very, very important. It checks for the anterolateral rotatory instability. Posterior cruciate ligament test, two tests are there, posterior sag test, posterior drawer test. When we hear the name sag, like sag means what? It's like absence of bulk. You consider the case of a sack, a filled sack is firm, right? So when the sack is out of sand, what happens? It feels like a loose structure. So this is what we mean by the sag test. So sag test checks for the integrity of posterior cruciate ligament. So here the patient is in supine, the hip is flexed to 45 degree and knee is flexed to 90 degree. So as I said, these all specific degrees are very, very, very important, because sometimes you will get the special test correct, but you will make the degree side wrong. So whenever we learn about the special test, we need to be aware about the degrees by which we are executing the test. So the sag test, hip is flexed to 45 degree, knee is flexed to 90 degree. So when a person is viewing laterally, we can see that the tibia is sagging posteriorly relative to femur. So when we consider the tibia and femur in a flex position, normally it makes an angle, right? So if the tibia is sagging backwards, it will create an impression in the tibial tubercle. So that is posterior sag test. Coming to posterior drawer test, this posterior drawer test checks for the integrity of posterior cruciate ligament. In anterior drawer test, we told that we are trying to glide the tibia anteriorly. We are going to give an anterior glide to the tibia. So in posterior drawer test, hip joint is flexed to 45 degree, knee joint is flexed to 90 degree, and then the tibia is glided posteriorly. This excessive posterior glide gives a positive sign for the posterior drawer test. Coming to Lashman's test. Lashman's test gives, as we told, Lashman's test gives excessive glide for the anterior cruciate ligament, excessive joint play to the anterior cruciate ligament. So reverse Lashman's test, as we say the term reverse, it is for the posterior cruciate ligament. So the procedure here is, what we do is the knee joint is flexed to 30 degree and therapist stabilizes the femur, and posterior drawer test we try to give a posterior glide to the tibia. So if there is an excessive posterior glide, that prevents the there is excessive laxity, or the tibia will glide excessive in a posterior direction. Meniscus and plica. We know meniscus, there is a medial meniscus and a lateral meniscus. These meniscus are structures that takes compressive load in the knee joint. Okay, so whenever we apply a compressive force, these meniscus are automatically getting stretched or stressed. So McMurray's test, it's used to identify the meniscal tear. So here the patient is in supine and knee joint is in maximum flexion. So we are trying to, when we are trying to do a internal rotation and we are trying to extend the knee, okay, when we try to do a internal rotation and extend the knee joint, the lateral meniscus is stressed. So internal rotation with extension, lateral meniscus is stressed, and external rotation with extension, medial meniscus is stressed. So normally for the meniscus, we have to check that internal rotation and external rotation, both are equally important to check the different meniscus. Internal rotation with extension checks the lateral meniscus, while external rotation with extension checks the medial meniscus. So this McMurray's test helps in reproducing the click or the pain syndrome. So mainly it is a meniscus. Compression causes the pain. If it's a compression, that means that meniscus is the structure. So meniscus mainly takes the compressive load. Apley's test. Apley's test differentiate between the meniscus and the ligamentous lesion. So here, in case of Apley's test, patient is in prone and knee joint is flexed to 90 degree. So meniscus, we know a compression causes the pain or symptom. But at the same time, a ligamentous structure means distraction or a stretch force will cause the symptom. So if we are distracting the knee joint and rotating the tibia and the patient is complaining of pain, that shows mainly of a ligamentous dysfunction. So a compression, if the compression and rotation causes pain, that signifies that meniscus is the tissue at fault. So this is regarding meniscus and ligament differentiation. Huxton's plica test, this checks out for the plica dysfunction. So here the patient is in supine, the knee joint is flexed and internally rotated. So while palpating the medial femoral condyle, what the therapist does is, the therapist glides the patella medially and tells the person to passively flex and extend the knee. It's not tells the patient, it's the therapist himself doing passive flexion and extension. So if the patient complains of pain or a popping sensation, that shows that Huxton's plica test is location. So here the patient is in supine, so the therapist glides the patella laterally. So if the patient shows apprehension or forcefully forcefully try to hold the lateral glide through the muscular activity, that shows that patellar apprehension test is positive. Clark's sign specifically checks for patellofemoral dysfunction. This is from an exam point of view, This is very important topic. Clark's sign checks for patellofemoral dysfunction. And here the patient is in supine. What therapist does is he places his hands on top of the patella and asks the patient to contract the quadriceps muscles. When the patient is contracting, he tries to approximate the patella to the tibiofemoral junction. So if a pain is produced, or if the pain or discomfort is produced in the same way the patient feels his original symptom, that shows that a patellofemoral dysfunction is present. So remember, for patellofemoral dysfunction, the test is called Clark's sign. Palatable patella or patellar tap test. This specifically checks for the patellofemoral effusion. So mainly infrapatellar effusion. So if a question comes, palatable patella checks for patellar effusion or infrapatellar effusion, the correct answer would be infrapatellar. So always our aim is to select the best answer possible from the combination. So here the patient is in supine. The therapist generally taps the center of the patella. So as we know, like if it's a fluid filled area, the patella would be dancing, like it's like a floating patella where the patella won't be firm, it would be soggy. So the positive finding is a floating or a dancing patella. Fluctuation test. This fluctuation test is to check for the knee joint effusion. So what the patient is supposed to do is, patient is in supine, therapist places one hand above the patella and one hand below it, and he pushes the patella up and down with each hand. So we know normally there is a bony feel when we are moving the patella. So if there is an excessive effusion, what we can see that we can feel the ripples of the fluid. So whenever we are moving the patella up, down and sideways, we can feel the fluid ripple. So if such a ripple feeling is felt, that is called as fluctuation test. Q angle measurement or quadriceps angle measurement. It measures the angle between the quadriceps and patellar tendon. So it's 13% in men and 18% in women. The physiological reason is attributed to the wider pelvis. So if there is any alteration in this normal range in a gender specific assessment, that signifies a dysfunction. Noble compression test. This noble compression test signifies the iliotibial band friction syndrome. So the patient is in supine, the hip joint is flexed to 45 degree, knee joint is flexed to 90 degree. The pressure is applied to the lateral femoral condyle. So when a therapist applies the pressure to the lateral femoral condyle and then requests the patients to extend the knee. So while extending the knee, if there is a pain, discomfort felt in the lateral condyle region, that is a positive sign. And normally this pain syndrome specifically appears during the 30-degree flexion. So this 30-degree flexion aspect is also very significant. Tinel sign. Tinel sign commonly checks for the dysfunction of common fibular nerve. So procedure, we know that the common fibular nerve passes around the neck of the fibula. So the therapist taps at the direction of fibular head. So precisely behind the fibular head. A positive sign indicates the presence of tingling or paresthesia. If a person complains of tingling or paresthesia, that shows that the Tinel sign is positive for common fibular nerve. So that finishes the question discussion of this session, and within a short time we will come back with the MCQs and take things ahead. Welcome everyone. So we are back with the question discussion. So here I am making a change here. Today's question discussion, I'll be dictating the questions to you in a slow manner, and from the options you have to come to the conclusion, because I believe that in the theory class you might have got a brief idea. So every time if we give feedback regarding the right question, that won't be a correct approach. What we request is just look into these questions, look into the options and go and cross check yourself if you have a confusion regarding that. So let your motor cortex also work in a certain aspect. Question number 1. So let me read this. I hope your notebooks and notepads are there with you so that you can jot down the correct option. Question number 1. A 22-year-old soccer player sustains a non-contact injury while pivoting. She reports feeling a pop in her knee, following by immediate swelling and feeling of instability. The physical therapist performs a test by placing the knee joint in 20 to 30 degree flexion, stabilizing the femur and gliding the tibia anteriorly. This maneuver reveals excessive translation. Which test was performed and what is the most likely diagnosis? Option A, valgus stress for a MCL tear. Option B, posterior drawer test for a PCL tear. Option C, Lashman's test for ACL tear. Option D, McMurray's test for meniscal tear. So the question says that there is a feeling of instability, knee joint is in 20 to 30 degree flexion, tibia is glided anteriorly and there is excessive translation. So all these small hints are enough to give you a guidance towards the answer. So try to find out which would be the correct answer in that. Question 2. A physical therapist is evaluating a patient who complains of knee pain and locking. To assess the medial meniscus, the therapist brings the knee into maximum flexion. Which combination of movements should the therapist perform next according to McMurray's test? So, to assess the medial meniscus, which test pattern should be performed? Option A, internally rotate the tibia and extend the knee. Option B, externally rotate the tibia and extend the knee. Option C, apply a varus force and extend the knee. Option D, apply a valgus force and flex the knee. So the key pattern is, key combination that we points in the question that we need to remember is, it's medial meniscus, knee joint is brought into maximum position. So what is the next test pattern that need to be followed? So we had already discussed in the theory section how we differentiate between the medial meniscus and lateral meniscus. During an evaluation, a patient is positioned in supine with hip flexed to 45 degree and knee flexed to 90 degree. When observing the knee from the side, the therapist notes that the proximal tibia appears to be dropped posteriorly in relation to the femur. This observation is most indicative of positive, which positive test? So that's a question. Pivot shift test, option A. Option B, posterior sag test. Option C, Lashman's stress test. And option D, fluctuation test. So hip flex to 45 degree, knee flex to 90 degree. Looking from the side, the therapist feels that tibia is dropped posteriorly. So the hint is clear here. I think there is no need to guide you towards the answer for this question. Question 4. A 19-year-old football player is tackled from the lateral side, causing a significant valgus force to his flexed knee. The therapist suspects an injury to the medial collateral ligament. Which of the following is the correct procedure to test the integrity of medial collateral ligament? Option A, with knee joint flexed to 20 to 30 degree, push the knee outward, varus force. Option B, with the knee fully extended, push the knee inward, valgus force. C, with the knee flexed, push the knee inward, valgus force. Option D, passively glide the tibia anteriorly on femur. So the key points here are: a player is tackled from the lateral side. The physiotherapist wants to check for the integrity of medial collateral ligament. So you need to remember whether it would be a varus force or a valgus force, or regarding the angles of the knee joint that you are planning to test. Question 5. A patient is in prone position with knee joint flexed to 90 degree. The therapist first distracts the knee and rotates the tibia, which elicits pain indicating ligamentous dysfunction. Then the therapist applies a compressive force to the tibia and rotates it, which elicits pain indicating meniscal dysfunction. Based on Apley's test, what does these findings suggest? The patient has only ligamentous lesion. The patient has only meniscal dysfunction is option B. Option C, the patient has both ligamentous lesion and meniscal dysfunction. Option D, the test is inconclusive. So we talked about Apley's test, and we told that how we are going to differentiate between the meniscus and ligamentous lesions, which are the forces that are applied. So based on the whole discussion point, or based on the assumptions given, the answer is clear. So the statement correctly says that while compressing also a pain is there, distracting also a pain is there. A physical therapist is attempting to identify anterolateral rotatory instability in a patient with suspected ACL tear. The therapist positions the patient in supine and internally rotates the tibia. He applies a valgus force and slowly flexes the knee. At approximately 35 degree flexion, a clunk is felt as the tibia reduces to its original position. What does this test describe? So all this explanation forms part of which test? That is the basic question. So the key aspect here, anterolateral rotatory instability. So we told, like, if it is anterolateral, which all structures might be involved in it. So option A, posterior drawer test. Option B, Lashman's stress test. Option C, McMurray's test. And option D, pivot shift test. Question number 7. A patient with a history of recurrent patellar dislocations is being evaluated. The therapist gently pushes the patella in lateral direction. The patient immediately tenses their quadriceps and express that their kneecap feels like it is going to pop out. This response is indicative of option A, Clark's sign. Option B, palatable patella test. Option C, patellar apprehension test. Option D, Huxton's plica test. So the key point here is recurrent patellar dislocation and the patient feels like the knee is going to pop out. So this guides you towards the right answer. Question 8. A long distance runner reports sharp pain on the outside of their knee that typically begins after 2 miles of running. The therapist positions the patient in supine with hip flexed to 45 degree and knee flexed to 90 degree. The therapist then applies firm pressure over the lateral femoral condyle while passively extending the knee. The patient reports severe pain at 30 degree of flexion. This finding is consistent with option A, lateral collateral ligament sprain, option B, common fibular nerve entrapment, option C, distal IT band friction entrapment syndrome, option D, meniscal tear. So the key hint here given is during the initial 20 degree flexion, lateral femoral condyle pressure is applied, patient complains of pain. So that's the guiding point towards finding this answer. Question 9. A patient sustained a direct blow to the front of their tibia while their knee was bent, such as a dashboard injury. To assess the integrity of posterior cruciate ligament, the therapist places the patient in supine, hip flexed to 45 degree and knee flexed to 90 degree. What is the next step in performing the posterior drawer test? So this one is relatively very easy. It can't get easier than this. Option A, B, C and D. Option A, passively glide the tibia anteriorly. Option B, passively glide the tibia posteriorly. Option C, apply a varus force to the knee. Option D, ask the patient to contract their quadriceps. So the main thing is they have told that the injury is for the posterior cruciate ligament. Question 10. A therapist is evaluating a patient for anterior knee pain. The patient is in supine with the knee extended. The therapist applies pressure on the superior aspect of patella and asks the patient to gently contract the quadriceps. The patient reports of significant pain within the knee joint. So this is a positive finding for which test? So we have told that anterior knee joint pain, we are pressing the patella and telling to contract firmly. So this should give you the hint what should be the choice. Option A, patellar apprehension test. Option B, Clark's test. Option C, Noble compression test. And option D, Tinel's sign. Question 11. A patient presents with significant swelling throughout the knee joint following a traumatic injury. The therapist places one hand superior to the patella and other hand inferior to it. He then alternates pushing up and down with each hand. The therapist feels a movement of fluid from one hand to other. This test is known as option A, balletable patella test. Option B, fluctuation test. Option C, patellar tap test. And option D, posterior sag test. So the guiding factor here is the movement of fluid from one point to another. Question 12. A patient reports of pins and needles along the dorsum of the foot, falling and hitting outside of the knee. The therapist firmly taps the area just posterior to the fibular head, which reproduces the patient's symptoms. If the test is positive, it suggests the dysfunction of, so pins and needle sensation posterior to the fibular head. This is the guiding aspect. So option A, tibial nerve, option B, saphenous nerve, option C, common fibular nerve, and option D, sural nerve. During the theory discussion, we had already mentioned the name of the nerve, so you can do a slight exercise of your memory also. A physical therapist measures the female patient's Q angle and finds it to be 21%. According to the reference range, what is the significance of this finding? A, it is within the normal range for a female and is insignificant. It is below the normal range for a female and indicates a varus deformity. C, it is above the normal range for a female patient and it indicates a biomechanical dysfunction. Option D, it indicates a patellar dislocation. So we told that for males and females, the reference range for a Q angle is different. So based on that assumption, we can come to a conclusion. Question 14. To test the dysfunction of medial plica, a therapist places the patient in supine. The therapist flexes the knee, internally rotates the tibia and glides the patella medially. While palpating the medial femoral condyle, the therapist passively flexes and extends the knee. A painful popping is reproduced. This describes a positive. Option A, McMurray's test. Option B, pivot shift test. Option C, Huxton's plica test. Option D, Clark sign. See, already there is a hint given that we are going to check for medial plica dysfunction. So answer is very evident from the options. Question 15. A patient has a swollen knee. The therapist gently taps on the center of the patella and perceives that it is floating rather than firmly connected to the femoral groove. This finding is a positive patellar tap test, also known as palatable patellar test, and this indicates option A, patellofemoral dysfunction, option B, knee joint effusion, option C, infrapatellar effusion, option D, dislocated patella. So the key hint here is patella is floating. So this should guide us towards the correct answer. Question 16. A patient is in prone with knee joint flexed to 30 degree for PCL integrity test. The therapist stabilizes the femur and attempts to glide the tibia posteriorly. Which procedure describes this test? So very obvious answer would be there. 1. Option A, posterior drawer test. Option B, posterior sac test. C, Apley's test. Reverse Lashman's test is option D. See, it's very clear, PCL integrity, so how it should be gliding, it's very evident. Question 17. A therapist is performing a McMurray's test on a patient. To specifically test the integrity of lateral meniscus, the therapist should start with knee maximal flexion and then option A, externally rotate the tibia while extending the knee. Option B, internally rotate the tibia while extending the knee. Option C, apply valgus stress while extending the knee. Option D, apply a varus stress while flexing the knee. The guiding point here is, it is McMurray's test and we want to check for the integrity of lateral meniscus. Question number 18. The patient is placed in supine with knee joint flexed 20 to 30 degree to check for the collateral ligaments. The therapist applies a force that pushes the knee joint outward or laterally. This varus force assesses the integrity of which structure? Option A, medial collateral ligament. Option B, anterior cruciate ligament. Option C, lateral collateral ligament, and option D, posterior cruciate ligament. The guiding point here, varus force, knee is pushed outwards or laterally. We want to check for the collateral ligament, so you have to come to a conclusion regarding which would be that collateral ligament. Question 19. A positive pivot shift test is identified by the palpable and visible clunk of the tibia relocating at 30 to 40 degree of knee flexion. This reduction is caused by the pull of which structure? Option A, hamstring muscle. Option B, quadriceps muscle. Option C, iliotibial band. Option D, popliteus muscles. Those who have given their full attention in the theory discussion would be able to answer this. Coming to the last question, question number 20. A patient is being evaluated using the Apley's test. The therapist performs the test by first applying distraction force and then compression force. The patient reports pain only during compression and rotation. This strongly suggests option A, ligamentous dysfunction, option B, meniscal dysfunction, option C, patellofemoral dysfunction, option D, iliotibial band friction syndrome. The guiding factors here, the patient reports pain only during compression with rotation. So think, when we are applying compression with rotation, which would be the structure that would be at fault, and come to a conclusion. So this is a set of 20 questions that we have discussed. Why I am not providing answers this time is because I want you guys seriously to listen carefully to the theory section and use your own cognitive skills to arrive at a conclusion. So it's me, Bipin Prasannan, signing off. I am thankful for Bemax Academy for giving me this opportunity to share my minimal knowledge here. So I would like to invite you all to explore the possibilities of Bemax Academy, where we try to train you towards the best way, where we try to train you guys towards the best way in your journey of success for licensure exam. So thank you everyone, thank you for your time. Wish you a great day ahead. Till we meet next time, it's a good day from my side and Bemax Academy. Thank you everyone.